بسم الله الرحمن الرحيم. كل عام وانتم بخير، رمضان كريم. We'll talk about the head injury. المحاضرة طويلة شوية بنحكي the first few slides يمكن شوية boring لأن الكل بيحكوا على basic neuro science و basic neurophysiology, but it's important to understand the management of the head injury. This slide is just to show you that the neurosurgical procedures, cranioplasties, burr hole, even shunting procedures were done in ancient civilization by the Egyptians or Egyptian civilization and by the Red Indians in North and South America. Some basic about the neuroanatomy and neurophysiology. You know, the brain is 2% of the body weight and it does extract 18% of the oxygen and 20% of the cardiac output. The actual weight of the brain is 1,400, but floating in the CSF, it's only 25 grams. This is just to show that the blood-brain barrier, which is broken in head injury and certain diseases within, like infections and even tumors, the blood-brain barrier is formed mainly by the endothelial tight junctions in the cerebral capillaries and strengthened by the astrocytic processes. And this is to prevent the toxic material from passing from the capillaries to the sensitive neuronal cells. What is allowed to pass is mainly oxygen, glucose, water, and certain amino acids for the synthesis of neurotransmitters. The blood supply of the brain comes from 2/3 comes from 2 carotids and 1/3 from 2 vertebrals. The circle of Willis, which is taught to you classically, is present only in around 60% of the cases. In 40% of the cases, it's the posterior communicating artery or anterior communicating artery is absent or hypoplastic. Some basics about the CSF flow, you know, this is a circulation with continuous secretion and absorption every time, so there's no starting points. Let us assume that the CSF is secreted from the third ventricle, from the choroid plexus. As you know, these CSF secretions, 80%, 85% from the choroid plexus and 10-15% from the ependymal lining of the ventricles. And when needed, every cell, whether neural tissues or glial tissue, is capable of secretions. From the lateral ventricle through foramina of Monro to the third ventricle to the aqueduct of Sylvius to the fourth ventricle, and then from the fourth ventricle through the foramina of Luschka and Magendie to the subarachnoid space, and then reabsorbed through arachnoid villi to the venous system. The rate of secretions of CSF is around 18 ml per hour. That means around 450 ml per day. The actual amount of CSF present at any time in the cranial cavities and in the spinal cavity is around 150 ml. 75 in the cranial cavity and 75 in the spinal cavity. That means the turnover of the CSF is 3 times. 3 times it's secreted and reabsorbed every day. The function of the CSF is protection, and it does help in distributing the nutrients to different parts of the brain. And what about the immunity of the CSF? The CSF lacks the cellular and lacks the humoral immunity. So there is no white BCs. The normal white blood cell count in the CSF is 0, and the antibodies is absent also. So, and this is important to show you that the risk of meningitis or cerebritis is high when there is skull base fracture with rhinorrhea or otorrhea. Just remember, this slide is actual functional real MRI showing the CSF or the brain pulsation, CSF or brain pulsation, because of the continuous circulation of the CSF and also because of the blood. This slide, just remember it, is going to help us in certain cases and will harm us in other case. The neural venous sinuses, just remember that the venous drainage of the brain, it's complex and is not our talk in this lecture. Just remember that ultimately the whole, whether superficial and deep venous drainage, ultimately goes to the internal jugular artery. And this help us just to remember in the management of head injury, like any patients come to us with head injury and brain edema, it's important not to block the venous drainage, because blocking the venous drainage will increase the ICP, the intracranial pressure. So that's why we ask the nurses in the ICU to keep the head up position 30 degrees and to keep the neck of the patient in neutral, uh, and that is to enhance the venous drainage and to prevent congestion, and so the rise in the CF in the ICP. The cerebral blood flow and cerebral perfusion pressure. The cerebral blood flow uh, is 55 ml per 100 gram of brain tissue per minute, and this is fixed because of autoregulation. When the CSF, when the cerebral blood flow fall between 18 and 55, there is reversible ischemic damage, and if it is below 8, there is infarction or necrosis or death of the neurons. Remember that the cerebral perfusion pressure equals the mean arterial pressure minus the ICP. That means, and this cerebral perfusion pressure should always be kept above 70 millimeter of mercury. That means when we want to assure that the CPP is well, we have to raise the blood pressure and we have to decrease the ICP. What about the autoregulation? The autoregulation, as we mentioned previously in the previous slide, the cerebral blood flow is fixed and is unrelated to the patient condition, whether he is resting or exercising, unlike the muscles or GI tract or other parts of the or other organs in the body. And this is done by the this autoregulation is meant to keep the cerebral blood flow fixed at 55. In case the blood pressure falls down, then there is vasodilation, and when there is high blood pressure, there is vasoconstriction to keep the cerebral blood flow fixed at 55. And this autoregulation is lost in head injury, cerebritis, infections, or tumors. But there is a limit for the autoregulation. That means the autoregulation will work only when the mean arterial pressure between 60 and 150. If the mean arterial blood pressure falls below 60, then there is ischemia. And if the mean arterial blood pressure rise to more than 150, then gradually there will be hyperemia, edema, and then possibly hemorrhage continue to rise. The Monro-Kelly hypothesis is not important to just remember the name, just remember the idea. The skull is a closed box, the brain, and in this closed box there is three components mainly: brain 80%, blood 12%, CSF 8%. This hypothesis says that any rise in one component must be offset by equivalent decrease in another one, and that is to prevent the rise in the ICP. Just take an example. If the brain tissue is increased by, say, a brain tumor, then there must be a mechanism to decrease the ICP. And this is compensated, the increase in the brain tissue is compensated by decrease in the blood flow and decrease in the CSF secretions, and so forth. The normal ICP, there is no normal ICP, it's a range. In adult, it's between 5 and 18 millimeter of mercury, and depends on the age. In children, it's 0 to is very low, 0 to 5, and that's because the anterior fontanelle and sutures are open. And just try to differentiate between acute and rapid rise in the ICP versus chronic rise in the ICP. How much the brain can tolerate acute rise, it's that the acute rise in the ICP can be tolerated up to 25 millimeter of mercury, and while chronic rise can be tolerated even if it reaches 30-35, as we see in certain cases. When the ICP rises, there is compensatory mechanisms, normal physiologic compensatory mechanisms, without intervention to decrease the ICP. Say, what are these compensatory mechanisms? These are the 5 of them. displacement of the CSF to the spinal component, increase in CSF absorption, decrease in CSF production, and decrease in cerebral blood volume. Okay, and there are respiratory, renal, and endocrine mechanism. The respiratory, so the lung has a rule, the kidney has a rule, and the endocrine system has a rule. How? The respiratory, when there is rise in the ICP, there is hyperventilation. That is tachycardia, and that is because to wash out the CO2 from the blood. You know, the CO2 is acidic. When it is washed, there will be respiratory alkalosis, okay, which helps in causing vasoconstriction and reducing the ICP. And the renal, the kidney, also play a role in acid-base balance and plays the same role, while endocrine system through the antibiotic hormones. And this compensatory mechanism may fail in certain diseases as traumatic brain injury and others. This is just a diagrammatic representation of the Monro-Kelly hypothesis, as the brain can tolerate the increase in the volume, brain, CSF, like in hydrocephalus or hemorrhage in blood, but through the compensatory mechanism. When the mass increases, the ICP does not increase because there is compensatory mechanism, which we mentioned before, but up to certain limit. When there is huge rise in the large, very large mass effect, or very or hemorrhage, okay, we reaches the point of decompensation where there will be afterward herniation. As we mentioned, the rapid or acute rise in the ICP can be tolerated up to 25 millimeter of mercury. Okay, and that is, if we convert the pressure to a volume, it's equivalent to 120 ml of, say, blood can be tolerated in the brain. Okay, while slow increase can be tolerated up to 35 millimeter of mercury. This is to show you that, like ECG, there are ICP waves, okay, normal ICP waves and pathological ICP waves, but this is not important for you. The causes of high ICP are many. Just I will leave it for you to read it. Signs of high ICP. Just our talk. We are talking about the head injury. When there is head injury, brain edema, epidural hematoma, subdural hematoma, or brain contusions, okay, there is automatically a rise in the ICP. The signs of this start from headache, nausea, vomiting, and blurring of the vision. Then if the ICP rises more, there is decrease in the level of consciousness. After a few days, you may notice papilledema and ocular nerve palsy. Abducent and trochlear nerve palsy are very sensitive to any rise in the ICP. And Cushing triad. Just remember the Cushing triad, which is hypertension and irregular breathing. Okay. Hypertension, bradycardia, and irregular breathing or kinesthetic respiration. This slide is very important for you, and in every exam there is a scenario for you to assess the Glasgow-Coma scale. I hope you just remember this very, very well. The Glasgow-Coma scale in pediatric age group is the same, but the difference is the verbal response, because the child or infant cannot be assessed whether he is oriented to time, place, and persons. Our main talk now is about the head injury. We finished the boring slides and about the basic, but as I told you, it's important for understanding. Okay, the head injury is basically injury to the skull and the brain tissues. The causes are many. Classification of head injury according to Glasgow-Coma scale into, just remember, mild, moderate, and severe. Mild head injury from 14 and 15, moderate head injury between 9 and 13, and severe head injury between 8 and below. There is no, the Glasgow-Coma scale, just remember it. The lowest is even for a dead person is a 3. Classification of head injury according to the time from the insult into a primary traumatic brain insult or secondary traumatic brain insult or injury. Okay, What is the primary head injury? It's the injury which happens immediately after the trauma, and we have no rule in preventing them. Like what? Like brain contusions, like skull fractures, like the diffuse axonal injury. I put this slide to show that it depends on the luck of the patient. Okay, and we have no rule in preventing them once it happened. It depends on the luck of the patient, whether he fell down from fourth floor or from 1 meter, whether he had the car accident at high speed or low speed, etc., etc. While secondary brain insult are the injuries which happen as a consequences to the primary brain trauma. Okay, and here we have a rule. This is important for you to understand the management of the head injury. Here in the secondary brain insult, like what? Secondary brain insult, like brain edema, and which happens around the primary brain contusion or the primary hemorrhage. Okay. Then when there is edema, there is compression on the capillaries. There is breach in the blood-brain barrier. There is loss of autoregulation and influx of more and more fluid. Okay, and so the case will worsen gradually. Here we have an intelligent tool. We have an intelligent actions we can do to prevent the secondary brain insult. Okay. The cascade of events in case of primary to make you understand the primary and the secondary head injury. Say, for example, there is a primary hematoma. Around the hematoma or contusion, there'll be secondary edema, hypoxia, ischemia, rise in the ICP, loss of autoregulation, changes in the cerebral blood flow, cerebral perfusion pressure, brain herniation, damage to the blood-brain barrier, release of free radicals, influx of glutamate and calcium into the neurons, and ultimately the death of the neurons. And this is the cascade of events. It's in case of in secondary traumatic brain injury. And here comes our rule. When we want to treat the head injury, our aim is to prevent the secondary to prevent the development of secondary traumatic brain insult. Remember that the head injury alone rarely causes hypotension. The only cases where the head injury can cause hypotension is terminal stage after brain herniation. We call it the stage cardiovascular failure, when the medulla herniates through the foramen magnum and the cardiac and respiratory centers are compressed. Then only hypotension can happen, because we remember that the signs of high ICP, as we said, is Cushing triad, and Cushing triad is hypertension, bradycardia, and kinostoc or irregular breathing. So the rule, wherever there is increased ICP, is hypertension. Hypotension can happen only in these three cases. The second case is infants with large subgaleal or intracranial hematoma or significant blood loss from the scalp. Now we start to talk about the scalp injuries. Okay, there are around 4 types of scalp injuries, starting from Keffel hematoma. It's a collection of blood, okay, below the periosteum. Below the periosteum, I'm sure most of you have seen such things. The possible complication of this is anemia, jaundice, and calcification. Later on, organized hematoma and calcification. The treatment is conservative. Okay, you don't touch it. Leave it for around few days or 1 week or so. Then most of the cases subsides continuously without intervention, but monitor for the development of and correct the anemia or jaundice. Later on, after a month or two, if it becomes organized hematoma and no absorption or there's calcification, we can intervene. Caput succedaneum is diffuse scalp edema because of forceps delivery usually. Subgaleal hematoma is just like the Keffel hematoma, but it's different that it is above the periosteum, below the galea and above the periosteum. That's why, to differentiate it, it does cross the sutures. Here, there is uh, fronto-temporoparietal subgaleal hematoma crossing the coronal sutures in this side, and here bifrontal subgaleal hematoma. This slide just to show you the different layers of the scalp and to differentiate between the Kifel hematoma, which is below the dotted line, which is the periosteum here, while subgaleal hematoma, it's above the periosteum and it does cross the suture line. The fourth type of scalp injury is degloving scalp injury. Degloving scalp injuries, it's not necessarily associated with fractures or brain insult inside, although it looks ugly, the ugly injury, but the matter might be simple, just clean this debridement and suturing if there is no underlying insult. This is compound comminuted skull fracture. When any fracture is exposed to the outside, we call it compound. Okay, when there is multiple linear skull fractures, we call it comminuted. Now we'll talk about the brain concussion. We frequently see this entity in sport, like in boxers or football players. Okay. brain concussion بالعربي يعني ارتجاج دماغي. I'm sure many of you got this at a certain time in life. Okay, anybody who had trauma or direct blow to the head and had a loss of consciousness or just blackening for a few seconds or even a fraction of a second, sometimes minutes with loss of consciousness, we call it brain concussion. And usually it is simple. Brain CT and MRI is usually normal. But remember, if there is multiple brain concussion at the same day or in short period, then it will be converted to chronic traumatic encephalopathies, as you notice in boxers. Okay. The brain contusion is different. The definition, I forgot to mention about the definition of brain concussion. So even if the patient lost consciousness after blow to the head injury, and the brain CT and MRI showing normal anatomy, then what is the best definition? The best definition, I think, is just to say it is a physiologic loss of function of the neuron for a short period. Okay. While the brain contusion, there is anatomic damage. They frequently ask questions, or what is important for you to remember that the brain contusions, which is a small bleed from small capillaries, okay, the location, we commonly ask about the location of brain contusions. Just remember the frequent locations are in the pools of the lobes, the pool of the frontal, the pool of the occipital, the pool of the temporal, and at the base of the brain, not base of the skull, at the base of the brain. These are the frequent site of brain contusions. This is the person for showing the brain contusions in the pool of the lobe. Okay, and this brain CT scan showing right occipital contusion in the right side, the occipital pool, while here bifrontal brain contusion, large contusions, and there is high parietal and left occipital. This is then we'll talk about the skull fractures. There are types of skull fractures as well. You can see linear depressed skull fracture and basal skull fracture, etc., etc. We'll talk about each one by one. Okay, this is a linear skull fracture, skull X-ray showing the linear skull fracture in child, and this is CT scan showing the actually depressed skull fracture on the right temporoparietal area with overlying subgaleal hematoma and underlying brain contusion. And as you see here, there is midline shift from the right side to the left side. Usually we do operate as a rule, if there is midline shift more than half centimeter, this is the midline, see, and we assess the degree of the midline shift. Any midline shift more than half centimeter is indication to do surgery for the depressed skull fracture or for the brain contusion. The other linear and diastatic skull fractures in pediatric age group, when there is multiple linear skull fractures in pediatric or in infants, you should always suspect a child abuse. While the diastatic skull fracture is not really a fracture or new crack in the bone, it's just separation of the normal sutures. This is a depressed skull fracture in infants. We call it a ping pong fracture, just like the tennis ball. The treatment in this case is, although it looks ugly, and we don't rush for surgery in case of, because the bone is cartilaginous and soft, it can be compressed inward easily. The treatment is just conservative in most of the cases. Remember the first slide which I showed you about the CSF or brain pulsation. I told you it is going to benefit us in one case, and the brain pulsation or the CSF brain pulsation will push this depressed skull fracture in infants in most of the cases, more than 95% of the cases, to a normal position without intervention. After a month or 2 months, if it did not correct itself, then we can do surgical elevation. The treatment or the surgery, the operation for depressed skull fracture is elevation. Just remember this. Okay. While the treatment for the linear skull fracture is conservative. This is, as I told you, when there is multiple fragments of the bone, we call it comminuted skull fractures. The skull base fracture is important. We usually ask you to mention 3 or 4 signs of anterior skull base fracture or the middle skull base fracture. Just the anterior skull base fracture signs are, as you can see here, raccoon eyes, subconjunctival hemorrhage, which is unlimited, and this is to differentiate it from the subconjunctival hemorrhage due to direct trauma. And here, as you can see, it's limited. While here it's unlimited. So if we ask you to mention, because the signs of skull base fracture, mention raccoon, anterior skull base fracture, raccoon eye, unlimited subconjunctival hemorrhage, rhinorrhea, anosmia can be also a sign, loss of smell sensation can be a sign of skull base fracture, and that is because of when there is anterior skull base fracture, there is interruption of the olfactory filaments passing through the cribriform plate and loss of smell. Okay, what are the risk of skull base fracture when there is rhinorrhea? This is MRI showing the CSF leak through the nose through a skull base fracture. There is a risk of meningitis, entrance of air into the skull, that is pneumocephalus. How to manage? This is CT scan, coronal cuts showing the skull base fracture, and then this is diagrammatic representation of the above the brain CT scan. How to manage this rhinorrhea? In most of the cases, we start with conservative management. First, give antibiotic, wait for around 1 or 2 weeks with bed rest. That position can give acetazolamide, which is Diamox, or acetazolamide to decrease the secretion of the CSF. After 1 week or 2 week maximum of conservative management, if the CSF leak still continue to drip through the nose, then we can put a lumbar drain so that the CSF is drained through lumbar area, and that gives chance for the this fistula to heal. Okay, if the lumbar drain fail after around 10 days or 2 weeks maximum, then we can go for the third step, which is surgical repair of the skull base fracture, whether endoscopic or open. As we mentioned, when there is skull base fracture, there is risk of entrance of air into the skull, and that is called pneumocephalus. Can be simple pneumocephalus or tension pneumocephalus. As you can see here, tension means one-way valve. The air is entering and is not allowed to exit, and that can cause compression and brain herniation. The treatment for this simple pneumocephalus is conservative. The treatment for this tension pneumocephalus is emergency burr hole and evacuation of the air. During when there is pneumocephalus, that means air in the skull, it's important to keep the temperature normal, because rise in temperature, as you remember in physics, any rise in temperature will cause expansion of the gas, and that will put pressure on the brain and may cause brain herniation. So maintain a normal temperature, okay, when there is skull base fracture and pneumocephalus, okay. And we, the air usually comes from the frontal air sinuses, or from the ethmoidal air sinuses, from the sphenoid air sinuses, or from the mastoid air cells in case of middle skull base fracture, as we'll see later on. Okay, and the treatment needs repair of the, in this case, repair of the posterior wall of the frontal air sinus. Now we can finish talk about the anterior skull base fracture and its signs. The signs of middle cranial fossa fracture are Battle sign. Battle signs is, we call it battle sign only if it appears after 48 hours of the injury. So if you see this sign or see bruises immediately after injuries or within less than 48 hours, this is not a battle sign, and this is not skull base fracture. Okay, this is external bruises. If it is seen after 48 hours, then it is, we call it battle sign, and it is a sign of middle cranial fossa fracture. Okay. Other sign of middle cranial fossa fracture is lower motor neuron facial palsy, and that is to contrast it with the upper motor neuron. So lower motor neuron facial nerve palsy on the same side of the injury, okay, or in the of the fracture, whether it is seen in the CT scan or not, is a sign of skull base fracture if it happens after trauma. This is other signs of a middle skull base fracture is otorrhea, that is CSF leak from the ear, or loss of hearing. Clival fracture, I think this is not for your level. I just leave for those who wants to, who have interest in reading about it. Okay. The brain edema. Generally there are two types of brain of edema anywhere, that is cytotoxic or vasogenic. The brain edema which happens in the after head injury is usually cytotoxic, and steroids has no role in preventing or reducing the edema after head injury. Okay. The sign of the brain edema in CT scan is loss of brain of the gray and white matter differentiation. You can see here the CT scan with diffuse brain edema. The ventricles are compressed, hardly seen. It's bilateral, and there is cisterns are not seen. This indicates brain herniation actually. Okay, so there is no role of steroids in brain edema related to head injury. And this is dead person with loss of gray and white, loss of geography of the brain. There is no sulci, cannot differentiate without the sulci and the gyri. There is entity called malignant cerebral brain edema, malignant cerebral edema. Here in the CT scan, there is bilateral brain edema, loss of gray and white matter differentiation, and there is midline shift to the other side. So how to treat this? And treatment of head injury, any basic treatment of head injury, as we mentioned, is to keep the head up position 30 degrees, keep the neck neutral to enhance the venous drainage, and so to prevent the rise in the ICP. Second line is to, if the patient is intubated, is to do hyperventilation to wash out the CO2. Okay, that is to make respiratory alkalosis or alkaline blood, and that will help in do vasoconstriction and reduce the brain edema. The third tool is to give something like mannitol or hypertonic saline to decrease the blood-brain edema and to decrease the ICP. While here, the midline shift is more than half centimeter, this needs emergency decompression. Emergency decompression, like what we did here, is bifrontal decompression. And we remove the bone and keep it in the bone bank in the theater. Bone bank in the theater is a fridge at minus 40 or minus 50 degrees. We keep it up to 6 months maximum. After 1 month, 2 months, when the brain edema subsides and the brain cool down, and we can do return the bone back in a surgery called cranioplasty. The vasogenic brain edema is seen usually in around the MRI, the CT scan seen around the brain tumors, and in this case, yes, steroids, dexamethasone can help, but not in head injury. Steroids in head injury are contraindicated. Okay. Traumatic subarachnoid hemorrhage. This is another entity of head injury. It's seen in the subarachnoid spaces. This is a normal CSF in the sulci, and this sulci filled with subarachnoid space. We call it traumatic subarachnoid hemorrhage. And you know, the most common cause of subarachnoid hemorrhage is traumatic. Okay, and there is risk wherever there is traumatic subarachnoid hemorrhage, there is risk of vasospasm and development of hydrocephalus later on. The treatment is usually in this case conservative because there is no midline shift. Here, this CT scan is showing small epidural hematoma on the right temporoparietal area. There's no midline shift. Small epidural hematoma on the right side with counter-coup traumatic subarachnoid hemorrhage and brain contusion on the other side. The treatment in this case is conservative. This CT scan is showing large epidural hematoma, and commonly we ask the source of bleeding in epidural hematoma is usually arterial and from the middle meningeal artery, which is a branch of external carotid artery. This is large epidural hematoma. There is significant midline shift to the other side, and this needs emergency craniotomy. So the treatment for the acute epidural hematoma when it is large and midline shift is emergency craniotomy and evacuation of the hematoma. While this is right frontal epidural hematoma, no midline shift, no compression, the treatment is conservative, but in this case needs observation in the ICU. This is epidural hematoma being evacuated during the surgery. You know, this is the dura is not open. We just open the bone and then we evacuate the hematoma and put the bone back to its normal position. Okay. This I will not talk. This is not important for you, I think. Just now we'll talk about the subdural hematoma. There are just remember the acute and the chronic entity. Acute means the blood is seen within the first few days up to a week. Okay, while chronic, the blood seen after 2 weeks. In the first few days, the blood is acute and seen hyperdense on the CT scan, while after 2 weeks, it's lysed and seen as hypodense in the CT scan. The treatment for acute subdural hematoma is emergency craniotomy and evacuation of the hematoma, and in many cases, or around 50% of the cases, we keep the bone also out. That means decompressive craniectomy. While treatment for chronic subdural hematoma, the blood is lysed like a motor engine oil. Okay, just burr hole and evacuation. Here craniotomy, here burr hole and evacuation. This is seen in car accident and for any trauma in usually young persons, while the chronic subdural hematoma is seen in elderly, alcoholics, and shunted persons. And this is because the brain is shrunken. The source of bleeding in chronic subdural hematoma is usually due to breach in the bridging veins. And here also in subdural hematoma, in acute subdural hematoma, the source of bleeding is venous from the cortical venous system. Okay, and this is to contrast it with the epidural hematoma, where the source of bleeding is arterial. In subdural hematoma, it is venous. This is surgery for acute subdural hematoma. As you can see, because the blood is clotted here and acute, we cannot evacuate it through a burr hole. We have to do craniotomy. The bone is open first, and then the dura is open again, reflected, and the dura is sucked out. Okay. When the brain is contused and edematous, we many times we cannot put the bone back, so back to the normal. So we keep it in the fridge, in the bone bank in the theater for a month or 2 or 3. Okay. When the brain edema subsides, then we can put the bone back to its position in a surgery called again cranioplasty. This is a person uh, during this period while we wait to put the bone back, we can put a helmet for protection. And this is the burr holes, two burr holes for, remember, burr holes for chronic subdural hematoma, is not for acute. Burr holes for chronic subdural hematoma. Subdural hygroma or effusion is seen usually in pediatric age group, and it mimics the chronic subdural hematoma because it is hypodense. But this, remember, this is not blood. This is CSF collection by frontal or by frontoparieto-temporal subdural uh, hygroma. The treatment is again, because it's CSF and fluidy, we can do burr holes, bilateral burr holes to evacuate it. Intracranial hematoma and intraventricular hematoma in head injury is rare, and when it is present, it indicates a very severe injuries. Most of these cases, they die or remain vegetative, unconscious for their life. Diffuse axonal injury, as the name indicates, it's an injury to the axons of the neurons because of sudden acceleration and deceleration, like a person driving in high speeds and hit some static object. Okay, there'll be a sudden deceleration with rotation, and in this case, the axons rotates around their own axis and get injured, and ultimately the neuron will die. The common the command site for the command site for the diffuse axonal injury, of course, because it's axonal injury, it means white matter. So we don't see the diffuse axonal injury in the gray matter. Okay, it's in the white matter, and the commonly seen in the corpus callosum. This is MRI. This is not brain contusion. This is the diffuse axonal injury in the corpus callosum. Again, this is MRI. This is the corpus callosum. This is not a contusion. This is diffuse axonal injury. Okay. And the other common site for the diffuse axonal injury is the white matter of the brain stem. It looks like contusion, but it's not. Probably this is the best slide to show. This is the normal neurons with axon. When there is acceleration, deceleration, there'll be rotation also. Injury to the axons, and ultimately the cell body will die. Brain herniation, I think just remember this three. The first one is subfalcine. This is the falx cerebri, subfalcine brain herniation. Okay, it can compress the anterior cerebral arteries and cause ischemia. The second is this tentorium, transtentorial. The uncus of the temporal lobe is herniated through the tentorium and may compress the midbrain and other vital structures and posterior cerebral artery and cause ischemia. The third entity is herniation of the tonsils of the cerebellum through the foramen magnum. It can compress the medulla and the cardiorespiratory center and vital arteries and veins here, and can cause death. Remember, this just to show, this is brain MRI sagittal cut. Show you a case of a patient who had depression days after lumbar drain. Remember that one entity, the treatment of skull base fracture with rhinorrhea or otorrhea is first conservative, as we mentioned, then we lumbar drain, then the third stage is surgery. The other fail. Okay. This is a patient who had rhinorrhea and treated by lumbar drain. Unfortunately, the nurses forgot to keep the lumbar drain at certain levels, so it has drained around 350, 400 ml per one day, and because of over drainage of the CSF, there is this brain herniation. This is a tentorium, this transtentorial herniation of the uncus of the temporal loop, and this is tonsillar herniation of cerebellum through the foramen magnum. Regarding the risk of epilepsy and head injury, just I want you to remember three things: that the risk factors are cortical brain contusion, not deep brain contusion; subdural hematoma, not epidural hematoma; and depressed skull fracture, because these three entities cause irritation of the cortex of the gray matter, and this predisposes to epilepsy. This is not important. Other complication of head injury are cranial nerve injuries. Just for diagnosis, this is a third nerve. This is uh, abducens nerve palsy. Lateral rectus is not functioning, and this is ptosis and dilated pupil. That's oculomotor nerve palsy. This is not very important for you. Just and this is dilated pupil, and this and fundoscopic examination of the fundi of the eye are showing optic disc atrophy. That means optic nerve injury. This is all this optic nerve injury fundoscopic is not important for you, I think. I will just bypass. This is optic nerve, this is carotid artery, and this is falciform ligament, which is a dural fold, okay, over the optic foramina as the optic nerve enters into the orbit. Sometimes occurs because the optic nerve get compressed by the falciform ligament injury and get blindness. They were doing 20, 30 years ago the surgical decompression. The frontal lobe is being retracted, and decompression of the falciform ligament. Okay, this slide is important, I think, for you, very important. The causes of delayed deterioration. Patients who come to the emergency room after significant head trauma, car accident, car turnover, or fall from second floor or third floor, but they came talking and walking. And the brain CT examination shows no neurological deficit, and the brain CT scan is normal. So wherever you see such scenario, don't discharge patient home, because there are 15% of these cases they may deteriorate within 24 or 40 hours. The causes of deterioration, if you send them back home, is delayed hematoma, not seen in the first scan; diffuse cerebral edema, not seen in the first scan; hydrocephalus, which may develop later on; tension pneumocephalus; seizure, status epilepticus; hyponatremia, or other causes. Okay, I would stress this is a very important slide for your future career. The management of head injury, as we mentioned, the aim is to limit this development of secondary brain insult and to overcome the lost autoregulation and the blood-brain barrier damage by strict control of the ICP and control of the CPP. The management of any injuries starts from the ABCs: airways, breathing and circulation, correct and assure good oxygenation, PCO2 and pH, reduce edema by mannitol, hypertonic salines or Lasix, that's furosemide, correct the anemia, head elevation 30 degrees, free abdomen, free neck, monitor the sodium, prevent hyponatremia, because hyponatremia will increase the brain edema, control the seizures, and manage the hypermetabolic state by early nutrition and sedation and muscle relaxant. Barbiturate coma, giving barbiturate, these were used in the past. Some people are still using it. Okay, and that is to sedate and anesthetize the patient, which may help in reducing the ICP. Hypothermia is not used widely in Russia and certain Eastern Europe countries. They're still using it. Steroid, as we mentioned, is not used. It's actually contraindicated because steroids increase the glucose, and glucose will increase the brain edema by osmosis. These are the conservative management of any head injury. Okay, this is the very basic. If all this fail, then we can proceed for surgery. Okay, craniotomy, or we can put ICP monitors if the midline shift is less than half centimeter. Okay, with EBD. This is ICP monitors. It's a small catheter through a small twist drill or small burr hole. It's inserted into the brain parenchyma or inserted into the blood, into the ventricles of the brain. There are two versions. One just to measure the ICP, and so that will allow us to give more monitor and to correct, etc., etc., and will give us early alarm that the hematoma is increasing. Of course, the ICP is done only in case in the patients who are intubated. Okay, and the other version of the ICP is the one which is put in the ventricles. Okay, it measures the ICP, and wherever the ICP is more than 25 millimeter of mercury, we can withdraw some CSF to reduce the ICP without surgery. Okay, I'm sure this EVD system, you have seen this in many cases in the floor in the past before the corona event. And anybody interested can come later on and we'll show him. All what we talk about now is about early complication of head injury. Now we talk about the late complication of head injury is something called post-concussion syndrome. Any person who got, as we mentioned, brain concussion in the first few slides may continue to suffer from vague symptoms like headache, nausea, vomiting, decreased concentration, insomnia, mood changes, loss of appetite, etc., etc., etc. This vague group of symptoms, we call it post-concussion syndrome. So if a person comes to you after minor insult, okay, with brief loss of consciousness, that is brain concussion, and keeps to come in the clinic for a month, 2 or 6 months, or sometimes year with these vague symptoms, try to believe him. Don't tell him that you are lying, etc. Okay, provided you did MRI and the MRI is normal, and then you can label him as post-concussion syndrome. The treatment is conservative, just assurance that you are going to get well in few weeks or months. Sometimes we give placebo, vitamin C, or whatever to comfort them. Other late complication is leptomeningeal cyst or growing skull fracture. As we mentioned, the treatment of linear skull fracture is usually conservative, but in 1% of the cases, okay, in 1% of the cases, okay, and in patients who are under 3 years age, okay, the linear skull fracture, because of brain pulsation. Remember the slides, CSF or brain pulsation. Because of the brain pulsation, the linear skull fracture does not heal. In fact, because of the brain pulsations, it widens apart, and this is called leptomeningeal cyst or growing skull fracture. The treatment is if early, if it is detected very early, it's is simple, as we come to see later on. Okay, remember, this is a child who comes to a doctor few days by his parents, claiming that they noticed this after a fall down. Okay, but they don't remember when. Okay, so many doctors diagnose this as subgaleal hematoma or Keffel hematoma. After this lecture, I hope any picture like this, don't, even if it is subgaleal hematoma or Keffel hematoma, just try to put your finger over it and or see it tangentially. If it is pulsating, then this is growing skull fracture, is not a subgaleal hematoma and is not Keffel hematoma. Okay, do CT scan, will show you this picture. If it is diagnosed early, the defect of the growing skull fracture is small. The treatment is simple, just small opening in the skull. We put a patch, a dural patch, to close the dura here, and that's it. And this is going to heal just like a burr hole. Okay, this is going to heal spontaneously. While if you misdiagnose him and tell this child, go back, no, this is subgaleal hematoma or this is Kipple hematoma, wait for a week or two, then the fracture is going to widen apart. As you can see, the brain will herniate and there is leptomeningeal cyst. Then the treatment is usually mainly the shunting procedure to push the brain back to normal, and then cranioplasty. Just remember, in a child who is less than 3 years old, cranioplasty. Okay, so and shunting. While diagnosed early, the matter is simple, just a dural patch, and that's it. Other complication of head injury is vascular. Remember, if we ask you, mention 4 possible complication of vascular complication after head injury. Just remember, mention carotid cavernous fistula, traumatic brain aneurysm, carotid or vertebral artery dissection, or development of arteriovenous malformation. So, carotid cavernous fistula, aneurysm, dissection, and AVM. This is case of carotid cavernous fistula. This lady, this is not subconjunctival hemorrhage. This is congested vessels in the because of carotid cavernous fistula. Carotid cavernous fistula means this is the carotid artery, this is the cavernous sinus, and you know the carotid artery passes through the cavernous fistula. If there is a tear in the carotid while it passes through the cavernous fistula, then the cavernous fistula will be the carotid cavernous sinus will be arterialized. There is high blood pressure in the cavernous sinus, which is transmitted to the ophthalmic arteries draining the eye, and there is congestion. Earlier, it appears like this. If you did not diagnose, then within a few days there is proptosis and loss of vision. So now wherever you see this picture after head injury, okay, just remember the possibility of carotid cavernous fistula. The diagnosis, just bring the stethoscope, put it over the eye, then you will hear bruise. This is diagrammatic representation of the carotid cavernous fistula, cavernous sinus, and this is MR angiogram showing superior ophthalmic vein is congested and dilated, causing the picture previously mentioned, and not treated cause proptosis and loss of vision. This is again MRI showing the carotid cavernous fistula and congested vessels. Other possible vascular complication of head injury is development of brain AVM. In few cases, after any linear skull fracture, there is risk of the development of dural fistula, dural AV fistula, 10, 15, 20 years after the injury. Traumatic brain aneurysm, I think there is no need, just remember that traumatic brain aneurysm can develop secondary to head injury. There is no need to go through the details. Okay, and wherever there's aneurysm, it can bleed and cause subarachnoid, spontaneous subarachnoid hemorrhage. Other complication of head injury, other than we mentioned before, is endocrinal complication. You know the pituitary glands, anterior and posterior, 6 hormones, 2 hormones. Okay, any of the 6 hormones from anterior pituitary or 2 hormones from the posterior pituitary can be compromised because of injury to the skull base, causing injury to the pituitary gland or to the stalk or to the hypothalamus. Okay, so the risk of endocrinal damage and endocrinal compromise after head injury is contusion in the skull base, in the brain base, in the hypothalamus, or skull base fractures, which may compromise the infundibulum and the stalk of the pituitary or the anterior or posterior pituitary. Other complications are infections, meningitis, encephalitis, brain abscess, epidural or subdural hematoma. This is MRI showing epidural empyema or epidural abscess. This needs emergency craniotomy or emergency boreholes and evacuation. Epidural hematoma MRI. This is subdural empyema. Just remember, if you remember, it mimics what? It mimics the chronic subdural hematoma, but usually the patients comes in more in severe symptoms with possibly fever and septic. Okay, and again, this needs emergency craniotomy, evacuation, and putting in drains that plus IV antibiotics for at least 3 months. Okay, this is subdural empyema, and this is interhemispheric subdural empyema. This CT scan, all this CT scan. This is interhemispheric subdural empyema. This is brain abscess, MRI showing brain abscess with midline shift, and this diffuse cerebritis and brain abscess in dead person. Uh, this radiation injury and tumors. Uh, there are many in the literature, many papers mentioning development of brain tumors, sarcoma, glioma, meningioma after head injury on the same side. Okay, we don't know whether this is related really to the primary head injury to the head, or is it because of exposure to many CT scan. You know, you can see patients in the floors in any hospital, okay, with head injury, okay, exposed to at least 10, 20 CT scan, and each CT scan, as you know, is equivalent to about 50 chest X-rays. That's too much radiation. Whether these brain tumors, which develop in rare cases related to that, to the radiation or to direct trauma, we don't know. Other late complication of head injury is hydrocephalus, and remember, I want you to remember that the hydrocephalus in after head injury is usually communicating type, it's not obstructive, it's usually communicating type. Other possible complication of head injury is degenerative CNS diseases like Alzheimer's disease, Parkinson, amyotrophic lateral sclerosis, and dementia pugilistica, which is seen in the boxers, and the story of Muhammad Ali Fly is well known. These are not an easy blow, and I'm sure you have seen many boxers with these diseases. Late epilepsy can develop in 1 to 5% of the cases. And this is the last slide. Systemic complication of head injury. Cardiac arrhythmias, although it looks odd, but if we give you a question, all of the following are possible complication of head injury except. So cardiac arrhythmia can be a complication of head injury, especially traumatic subarachnoid hemorrhage. Okay, so they can develop cardiac arrhythmias, they can develop neurogenic pulmonary edema, they can develop infection and bed sores. This is well known, but this looks odd, but remember they are. Okay, and that's it. Thank you and good luck.